Welcome to Adapting Class, and thank you for joining us. Today we'll be talking about some prioritization, a few questions on prioritization. Of course, this is the basis of your NCLEX. You can't take the NCLEX without mastering how to do prioritization. You can't do prioritization without knowing the content. So if you're trying to study, don't do prioritization question until you know the content. How do you do prioritization? There's so many formula that you can find on the internet, but I call it you have to be sharp, right? Whenever you see a question, ask yourself, is this a breathing issue, electrolyte shock, sepsis, airway, neurological problem, or is it pain? In this pain, the patient is going to lose their life, limb, or eyesight. Then if you don't see that, then you ask yourself, is this an unexpected finding for that particular problem? Because every problem is a priority. So is this an expected finding? I shouldn't worry about it, or something that is an expected finding that is worst of all. Now you can have a bunch of expected findings, but one of them is really bad. There's some that are not that bad. So you compare the rest, and then that will be your priority. At the same time, you just have 1 second to make a decision. Don't overemphasize, oh, this can be good, this can be good, this can be, well, everybody has a priority. But if you want to choose one, who do you think? The one who you think is going to die or something bad is going to happen to them. So they all can have a problem. One, maybe the one you're supposed to pay attention. So I tell you, just divide the question answer choice into three and then see what is going on, depending on which question they're asking you. It said the nurse received phone call, so you're supposed to return phone call. They're all clients. This guy had appendectomy, right? She surgery. They removed the appendix. It's been 3 days. No bowel movement. Should you worry about it? You got to go back to your content. What happened to a patient who is having appendectomy and 3 days no bowel movement? Those are the buzzwords of an underline. Anti-infective. What is it? For skin infection. And what is he doing? Reporting nausea and diarrhea, right? These are the way when you read it like that, it becomes more sense. It makes sense, right? I'm taking anti-infective and I'm having skin infection, and this is what is happening to me. Should I worry about it? It's been 5 days since I have ileostomy created. Now I have abdominal distension. I have nausea, and there's no output from the ostomy. Should I worry about it? I have hypertension, and I have severe calf pain when I walk, but when I'm at rest, nothing happens. Read it the way you understand it. You don't read it the way the examiner put it. And if you do that, prioritization will become easy. And you're on your way passing your exams. You have to master prioritization because you find it in every question they ask you, there's a prioritization, and every question is related to priority. Therefore, appendectomy, you take narcotic, you're not going to have bowel movement in 3 days. This is an expected finding. You take antibiotic for skin infection. Antibiotic causes diarrhea and nausea. Don't worry about it. Expected finding. 5 days after ileostomy. So it's been 5 days. You should be having a bunch of worry diarrhea through the ileostomy. Where now you distended. I don't expect you to be distended 5 days. I don't expect you to, you may have some nausea, but no bowel movement, for no ostomy output for 24 hours. You have a blockage. And if you have hypertension and you have severe calf pain, right? When you walk, it's severe. This is the definition of claudication. And therefore, that is not right. Even though he has what severe calf pain is when he's walking, probably hypertension has claudication, peripheral arterial disease, PAD. At rest is fine. This is suspected. Your answer is number C. So if you don't understand it, you find it difficult, You should check adult and class. You see a bunch of prioritization video and you can watch it. Okay. And it is aware of several clients in endocrine clinic. You can get questions like that. They'll take endocrine, they bring facts. That's why I say you can't do prioritization without the knowledge and the facts. So endocrine clinic, which client situation need priority intervention follow-up? So when you see that, bring all your content related to endocrine, right? And then break them down into different sections. Patient has Addison disease, is getting D5W and what? Normal saline. Is it something you should worry about? Is it expected? Is it a good treatment? If it is, let it be. Get rid of it. Okay, this is select or apply. You don't have to pick everything. Pick those you're confident. There's 5 answers. If you know only one, pick one. If you know only two, pick two. Don't over-select. Patient has Kuhn's disease. What is Kuhn's disease? Is getting what? Spironolactone. Is it true? Is it the management? Is it an expected finding or is it contraindicated for that? You have diabetes insipidus. You're getting desmopressin and the patient is oriented to only self. Is that what you expect? Is it worrisome? Are you surprised about that finding? You got to be sharp. You have hypothyroid. You're receiving levothyroxine and your pulse is 101. Something you should worry about? You have DKA. You're getting 0.9% normal saline and you smell like what? Nail polish removal. Which of this should surprise you? Which of this need a follow-up? These are content, right? So tell me, which one you think we need to follow up with? I've explained them to you in a way to analyze them. So who need to be seen? Addison disease, what lab work do you see? That's all. This is what you tell you. Sodium is low, right? Glucose is low. Potassium is high. Therefore, don't worry about it. You're getting glucose and you're getting normal saline. You have Crohn's disease. You have a bunch of aldosterone floating around, making you become hypertensive. Spironolactone will block aldosterone. Therefore, don't worry about this. You have diabetes insipidus. You're lacking ADH. I give you ADH, and now you only know yourself, oriented to self alone. Think about it. If you let oriented to self alone, what does that mean, guys? If you are oriented to yourself alone, what does that mean? That is the key buzzword for that question. What does that mean? It means you're confused. If you're getting desmopressin, you're going to retain water. You have become what? SIDH. SIDH is confused. Therefore, this is a priority. A client with hypothyroid, if I give you levothyroxine, your heart rate is going to go up. Levothyroxine speed things up. I'm making you hyperthyroid. 101 is fine. If you have DKA, I'm going to give you what? Normal saline. If you have DKA, you're going to smell like a nail polish. This is ketone. Ketone smell. This is an expected finding. It's just content. Don't worry about it. You don't have to pick it. If you pick it, you lose a point. DKA is being treated with normal saline, and the patient just smell like ketones, right? I expect you to smell if you have ketone, acetone, right? That's ketone body. So that's not unexpected. It's expected finding. Smell like a nail polish removal is a ketone. That's how you spell. So there's only one answer there. And that's that guy who is confused. It's just endocrine content. One question, I give you a bunch of endocrine stuff. Number 5, E is getting is treatment, and he smell what he's supposed to smell like if you have DKA. So that's the endocrine concept right there. Which client need priority follow-up based on the clinical finding? Based on this clinical finding, who do you think you need a follow-up? A client receiving amphoteric IV and then temperature of what? 100.5. The client are waiting for what? Dialysis in 2 hours and has a creatinine of what? 3. A client who refuses to eat after administration of degludec, right? A client 4 days post-transfusional surgery and has a temperature of 101.1. Once again, find the buzzwords in the question. I'm going to circle them for you and connect the dot. That is what I mean. Looking for the buzzword and then see if it's an expected finding. If you do that, this is going to be easy. Dialysis in 2 hours. My creatinine is 3, right? I refuse to eat after I've been given degludec. If you do that, the question becomes straightforward, right? I had transfusional surgery 4 days ago. My temperature is 101.1. So who situation you don't expect? Whose situation make you worry? Whose situation give you a pause? Whose situation you don't expect? This medication is for antifungal. When you give it to people, they are flush. The skin will flush, they'll get fever. Therefore, you give them antihistamine, you give them Tylenol to preemptively treat them. It's an expected finding. If you're on dialysis, I don't expect your creatinine to be normal. It's going to be 3. That's why the patient is going to dialysis. If you refuse to eat after I give you degludec, degludec is what? Is a long acting. You don't have to eat with food. Right? So you don't have to eat with food. So that's a problem. Right? So it's not, if you don't want to eat, that's fine. I give it to you. It's a long acting. It's not going to affect your glucose. If I give it to you, it's a slow acting, very long. So it's not a problem. If you have transfusional surgery, that means brain surgery. You can take this from there. And all of a sudden, your temperature is 101.1. It's been 4 days. This is meningitis. That's the beginning of meningitis. Brain surgery, fever, 4 days, you worry about meningitis. So that's the answer. So this is a meningitis. The nurse is aware of several clients at change of shift. Which client requires follow-up? Select or apply. Same thing, a bunch of them. So which of these require follow-up? So you have a client, Digoxin, right? It's reporting nausea. Do you think it's okay? Is it worrisome? Is it expected? Taking Digoxin, refusing to eat. On morphine, reporting what? Nausea. Is on lithium, reporting nausea. Is on lithium, refusing to eat. Is on Digoxin, requesting promethazine for breakfast. So digoxin with GI symptoms, digoxin with GI symptoms. If I give you morphine, you're going to have nausea. That is an expected finding. Don't worry about it. What is number one side effect of lithium? What is the number one side effect of lithium that you're supposed to know for your exams? Same thing, GI symptoms. Therefore, lithium, nausea is GI symptoms. Refusing to eat is GI symptoms. 4 and this is the same. I'm connecting the dots and showing you how they can ask you in different ways. What did I tell you? GI symptoms for digoxin is number one. If you're requesting promethazine, this is for what? Nausea. That means the patient still has nausea. Therefore, F is also a priority. Early signs of toxicity is GI symptoms for lithium and digoxin. The nurse is aware of for client a change of shift. The nurse will initially follow up with the client with who has what? Diabetes and a glucose of 200 after breakfast and an hemoglobin A1C of 9. As DVT receiving IV heparin with 50% reduction of platelet day 5 of infusion. As bronchitis receiving IV anti-infective with a temperature of 101.2 and a thick fluid sputum. As asthma receiving IV steroid with PaO2 of 98 and a glucose of 250. Don't get trapped. You want to see. Same thing, just break the thing into segment like I told you. You have diabetes. Your glucose is 200. After you eat breakfast, it's expected. Your hemoglobin A1C is 9. It's abnormal. But this does not tell me acute problem. 3 months ago, it tells me you're not being compliant with your medication. I'm not worried about you. You have DVT. You're getting heparin. There is 50% reduction of your platelets. 5 days. This is heparin-induced thrombocytopenia. That's a bad problem. Bad problem. Bad problem. You should be worrying about this. Bronchitis. You have an itis. I expect you to be on antibiotic. You're getting it. Your temperature is 101.2. Antibiotic is taking care of it. You have thick fluid sputum. That is the definition of bronchitis. Don't worry about it. You have asthma. What are you doing? You're getting steroid. You're on steroid. Your PaO2 is normal. If you're on steroid, your glucose go up. Therefore, don't pick D. You see how you can do this? It's not, don't let the NCLEX trap you. This is the way you connect the dots. You can see 3B is standing alone. So number 2 is standing alone. I don't expect the reduction. It's worrisome for me. And so that is a priority. Results need immediate follow-up. Select or apply. So once again, you're not supposed to transfuse patient and give them amphotericin at the same time because of the reaction are similar. You kill the patient. So which of these lab work should you worry about? You have to look at what you expect in that lab work and what you don't expect in that lab work. A decreased PTT for a client with DVT receiving continuous IV heparin. A glucose of 180 for a client with asthma who is receiving albuterol. A decreased INR for a client with pulmonary embolism who is receiving warfarin. 20% decrease in white blood cell count for a client with what? Bilobe pneumonia receiving anti-infective therapy. A serum sodium of 146 from 156 for a client with diabetes insipidus who is receiving desmopressin. A serum potassium of 3.7 for a client with this you say Addison disease who is receiving steroid therapy. The white blood cells of 13,000 for a client who is post-operative day 1 after amputation. All you need to do, find the pathways, see if it's unexpected, and then select or apply who need to be seen. That's all. A bunch of questions. I intentionally said it that, but this is to give you medication and how it works. So look at it. Is it unexpected? Connect the dot like the first one. Is PTT time, decreased PTT for a client with DVT receiving IV heparin, is it okay? If it's not, if it's good, then do. But this is the way your NCLEX will set it. They will try to trap you. And then look at it and see if it's an expected finding. If it is, let it go. If it's not, then you pick it. And you can see that these questions are not that they design for you to be able to answer it. But then there is a trap. So Which of this you think the net immediate follow-up with that? Which one? Look at it carefully. Look at it carefully. What are your answers? Those are your answers. So what are your answers? Let's go through them and see. PTT. I'm on heparin. If I put you on heparin, what do I want your PTT to be? What direction do I want your PTT to be? High or low? If I put you on heparin, high or low? If I put you on heparin, what should your PTT be? Guys, if I put you on heparin, what should be your PTT? Don't let these questions trap you. Should your PTT be high or should it be low? It's supposed to be high. If I put you on heparin, PTT is supposed to be high. Therefore, a decrease in your PTT is bad when you have DVT and you're receiving heparin. It's just the words of it, but think about it. The reason why the patient is on heparin is supposed to increase your PTT so that your blood doesn't clot. Therefore, thus you need to intervene. Your glucose is 180 for asthma patient who is receiving albuterol. Albuterol is agonist, beta agonist. It does the same thing like epinephrine, norepinephrine. Therefore, your glucose is supposed to go up. This is not a problem. I put you on warfarin for pulmonary embolism. Your INR is decreased. What should be your INR when you're on warfarin? Should it be high or low? Increase or decrease when you're on warfarin? Same thing. What should be your INR? If I put you on Coumadin, should it go up or should it go down? That is the concept. Don't forget, you know the thing, but then when they say the question, you got to figure out how to apply it. That's the test taking strategy. That's why I said focus on the buzzword. If I put you on warfarin, what should be your INR? It should be high, right? The normal INR is 1. If I put you on warfarin, it will turn into 2 to 3. Therefore, it has gone up, high. If your INR is decreased, it's bad. So I got to see you. 20% decrease in your white blood cells for a client with bilobe pneumonia receiving anti-infective, right? Anti-infective. That means if I give you antibiotic, okay, for pneumonia, your white cells is supposed to decrease. If it decrease, it's okay. Therefore, I'm not worried about you. Serum sodium of 146 from 156. So his serum sodium was 156. It went down to 146 for a client with what? Diabetes insipidus, because he's losing a lot of water. So his sodium is high. When you give them what? Desmopressin. You treating the DI, you give them desmopressin, you hold on to water, their sodium came down. Sodium is now 146. You're doing something good for the patient. Nothing wrong with it. This is okay. The potassium is 3.9 for Addison disease, right? It's Addison, who is receiving steroid. Yeah, Addison patient has hyperkalemia. When you give them steroid, their potassium will become normal. Their glucose will become normal. And then their sodium will become normal. Therefore, this is expected. Your white cell is 13,000 if you are post-op day one after amputation. After surgery, post-op day one, everybody white count goes up. This is not a problem. So this is expected. Therefore, you can see that there's only few answers there that are right. There's only two answers there. Two answers that you have to break them down slowly with your content. So is A is not good and C is not good. But the rest of them, they are all normal. So this one is a hard one. Okay, this is a GYN question. They are all G1P0. Don't worry about them. Different weeks. Don't worry about it. But one of them is reporting daily nausea and emesis. Another one is reporting excessive fetal movement after eating. Then one is reporting nausea and right upper quadrant pain. Another one is reporting bilateral leg edema after prolonged standing. Who is the problem? Who? Who is the problem? Uh, 12 weeks and you have daily nausea. It's expected, right? It's not upper emesis gravity yet that you're going to have nausea, emesis. It's not a problem. When you get pregnant, you eat, the baby move because it's happy. Yes, more movement. If you have right upper quadrant pain and you have nausea, close to third trimester, you probably have HEP syndrome. It's a variant of eclampsia, pre-eclampsia. This is dangerous. We got to do something quickly. If you're 38 weeks, you stand on your feet and both leg is going to swell. He said what? After prolonged standing. Don't just read edema and you think, oh, this is a pre-eclampsia. He said bilateral, both leg. But when? When the patient stand for a long time. Therefore, it cannot be pre-eclampsia. Is this one? So, four clients are in the emergency room after high-speed motor vehicle who need to be seen first. The same thing. Think about it. Prioritization 101. You have to be sharp. Who needs your second? Who is dead? Who is not dead? Who you can save? Multi-trauma. There's a bunch of people who come in. The person with the severe injury that is almost dead, let them die. Person with severe injury who you can save is the patient you save. I say focus on the red and the black and eliminate the black and then deal with the red. Red is your answer. So who is sick? Patient is confused after being unconscious for 3 minutes. Client with hyperresonance to percussion on the left chest. Multiple facial laceration and deformed leg, left leg, and cap refill less than 3 seconds. If you have to pick, who do you want to pick? You have to use the buzzwords. There's a bunch of buzzwords there. Locate them, underline them, and figure out who you need to see. That's all. It's confused after 3 minutes of unconsciousness. So this patient is like concussed. So this is post-concussive right now. It's a problem. You got to check them. Get a head CT. Make sure their head, there's no bleeding. You have hyperresonance on the left chest. Hyperresonance means there's a bunch of air in your chest. Okay, that is not supposed to be there. A bunch of air outside, and it's making noise. This is another way of saying tracheal deviation or tension pneumothorax. Hyperresonance is a bunch of air there. Patient can develop tension pneumothorax. This is bad. Multiple facial laceration. Of course, you catch yourself. You're not going to die from it. You have deformed leg. I know your leg is deformed, probably is broken, but your capillary refill is less than 3 seconds. That is a normal capillary refill. Don't fall for it. Don't fall for it. Once again, don't fall for it. I know it's deformed, but your vasculature is intact. This patient may be having tension pneumothorax. Those are the buzzwords. This is the way you do it. Superficial laceration, unconscious, and compared to them, he was unconscious, but he's confused now. But this one, hyperresonance in your chest, well, there shouldn't be hyperresonance in your chest. Nobody should have hyperresonance in your chest. You should have clear breath sound bilaterally. It should not be hyperresonance. Something should be ringing in your ear, buzzing, telling you, why will my chest make musical noise? It shouldn't. So I'll pick that. Next is as assessing a client in an outpatient clinic with fibromyalgia, reporting of suicide ideation. Which prescription during medication reconciliation require immediate follow-up based on the client's complaint? So you're doing medication reconciliation. So when you read a question, don't answer the question, break it down and find the buzzword in each question and then focus on it. I have fibromyalgia, underline it. I'm doing is reporting what? Suicide ideation. And then they asking me about medication. Why? You ask yourself, patient has fibromyalgia, is reporting suicide, and when you did medication reconciliation, you want to know which one you should worry about. This is the medication they're taking. They're taking Motrin, cyclobenzaprine, tramadol, and desipramine. All these medication can be used for management of fibromyalgia. Fibromyalgia is usually mostly a female, is a disease process where they have trigger points everywhere, multiple trigger points. It's a pain crisis syndrome. And so there are a bunch of medication to help with them. They have something, what we call modal therapy, right? This is multimodal therapy. So they're on all these medications to help with them. Therefore, which of this will you, which of this do you think you need to worry about? Suicide and medication. Look at the way I'm going to connect the dot. Fibromyalgia, you can take Motrin. Fibromyalgia, you can take cyclobenzaprine. This is Flexeril. You can take narcotic. What is this medication? If you can't recognize it, it doesn't mean it's wrong. Look at it. This is antidepressant. It's the most dangerous antidepressant in the world. TCA. You're going to die quickly. I call it TCA dance, right? But if you don't know, it's an antidepressant, right? And you don't know that it's a TCA. You know the major problem of antidepressant is suicide ideation. When you give it to somebody, they treat their depression, they get more energy, and they commit suicide. They commit suicide. A patient is now reporting suicide. Well, the medication that you give him to help with their body weakness and all the depressive symptoms, now they feel like they want to commit suicide. It's your TCA, which is an antidepressant. And that is what is causing the problem. Tramadol is not the problem. Benzoprine is not a problem. Motrin is not a problem. But the number one is antidepressant, the TCA. So that's your answer right here. Okay. And let's care for several clients in the mental health ward. Which client need immediate follow-up? A client on clozapine reporting drooling, clients on fluoxetine reporting insomnia, a client on perfenizine reporting inner feeling of restlessness, a client on amitriptyline reporting of fluttering in the chest. This is mental health farm is usually strategy. You have to know keywords about it. Look at it and say, is this I expect with this medication? If you expect it, then don't worry about it. If you don't expect it, then pick the answer. Look for the buzzword in each question and see which one you think is key for that problem, right? Clozapine, drooling, fluoxetine, insomnia, perfenizine, inner feeling of restlessness, and amitriptyline, flattening in the chest. and then connect it at that. Clozapine, one of the side effects is salivation. When you salivate, you're going to draw. It's not airway problem. Fluoxetine is SSRI. You take antidepressant, you won't be able to sleep. Don't worry about it. Perfenizine is a first generation antipsychotic. In a feeling of restlessness, it's akathisia. Don't worry about it. Amitriptyline, fluttering in the chest, this is arrhythmia. QT prolongation. Bad problem. Bad problem. Bad problem. That's your answer right there. Bad problem. And next is following a client. Which of the following client the nurse should see first when preparing for initial round? You have myasthenia gravis and you complain of leg pain. A client who just arrived on the floor post bronchoscopy. You had appendectomy, you are ready to go home. You have diabetes, you're reporting burning and tingling of both feet. Same strategy, do it. Expected finding, unexpected. Circle the bars where connect each other, and you have to be sharp when you select your answers and see which one you think is expected. If it's expected, what you know is going to happen, then ignore it. If you don't expect that, is worrisome, that is your answer. So which of this is a problem? That is your problem. Myasthenia gravis, I expect your leg to get weak. I don't care about you. You came for the floor for bronchoscopy. Yeah, that's an airway problem. I got to make sure your airway is intact. You have appendectomy ready for discharge. I have time for you, right? You have diabetes. You get peripheral neuropathy. Burning, reporting burning and tingling of the feet is expected. Therefore, this is not expected. And this is assessing a client in emergency room experiencing diabetic ketoacidosis. Which client finding require priority intervention? This is the same thing. I take the concept and I make the question out of it. You should not let it distract you. You should not let it disturb you. Look at it. Is it expected in DKA? If it is, then ignore it. If you don't expect it and you think they are all expected, but which one is worse, that's your answer. You may get a bunch of expected findings, but some of them are worse, then that's not your answer. The one that is worse is your answer. Which of this will you pick? And tell me, require priority follow-up. Patient has a DKA. Which one will you pick? If you have DKA, glucose is going to be 250. I don't care about you. Your respiratory rate will go up. You'll be hyperventilating. That's why it's 25. If you have DKA, definition of DKA is what? Acidosis. That's why you have it. A map of 59 is severe dehydration. I'm worried about you. Even though I expect that, this is all expected finding, but one is bad. That's why you give them fluid first. Map is 59. That is severe hypotension. And therefore, we got to worry about this rather than their pH because you know their pH is not going to be normal. Any last question? This is bonus for you, right? That's bonus for you. So client with AFib and a pulse of 92, client with CHF and a BNP of 50, 500, a client with pneumonia due for ceftriaxone, a client with myasthenia gravis reporting leg weakness. Who will you see first? CHF, definition, BNP greater than 100. This is fine. Myasthenia gravis, you're going to have leg weakness. Unless you worry about dysarthria, dysphagia, speech problem, I'm not worried about it. You have AFib, the pulse is 92, it's okay. And therefore, pneumonia, we need to give them an antibiotic to have a certain amount of concentration in the system. So that's the answer choice for that. That's the answer choice for this. So, guys, this is adapting class. If you're hearing my voice for the first time, welcome. I hope you learned something. If you want to know more about prioritization, then you can join our membership. You can like this video, or you can come to our crash course coming up. The address is over there. You can see, um, you can join in and you can register. We talk about all these content, and you get access to the questions I did, about 10 assessment. So like 850 questions, I guess, yeah. 10 assessment, and then a bunch of quizzes. So good luck, and take care of yourself. And then all the best of luck. Keep charging. You should never stop charging when it comes to adapting, because no matter what, keep charging. Bye bye.